about pharmacomythology. We live in an environment in which there's a huge amount of information assaulting us all the time in various ways. Every time you write an order in Epic, you're likely to get a little flag that says, hey, that's a bad medicine. And you're warned constantly about all kinds of things by insurance companies. I get 10 or 15 letters a week. You have this person on 2 neuroleptics. Did you know that? I did know it. There's a cheaper drug, and our algorithm says these 2 drugs are pharmacologically equivalent. This idea of pharmacological equivalence is so beloved of these people who make algorithms. They're equivalent in 100 people, but they're not equivalent in 1 person. And that's a thing that people miss all the time. And over the years, various people asked me to talk about this issue of how do we know what information we know and what do we actually know about drugs. And being a PhD pharmacologist, supposedly I know something about drugs, maybe. I have to disclose that I'm a therapeutic optimist. If you're a therapeutic optimist, you get people better that nobody else could get better. Just really exciting. I think the dosage needs adjusting. I'm not nearly as happy as the people in the ads. One of the places where information about drugs come from is TV for your patients. They are, as much as us, assaulted with information about what they should be doing, what they shouldn't be doing. Dr. Gartenberg has heard from a lot of people they shouldn't be taking all these medicines and his doctor's an idiot. So I'm going to describe some of the elements of myth that creep into the medical knowledge base, talk about the need for critical evaluation of the information you get. How do you critically think about what we're being told, and discuss ways in which information can be used for agendas other than for caring for patients. This is a patient who we saw in Myers 6, 22-year-old woman with fibromyalgia, POTS, TMJ, IBS. These are these dysautonomia patients that I've talked about in grand rounds occasionally. She has all of this stuff, and she's bipolar. She had an ANA, she had a tilt table that showed she has POTS, and she developed idiopathic thrombocytic purpura on Depakote, but it turned out not to be the Depakote. These are the failed med list on the left, and those are her current meds on the right. And every time I write orders for her, I get flags from Epic about every single drug, telling me that I'm doing things wrong. The tricyclic is too high, should be 3 times a day. She's on 2 different neuroleptics. I left one, no, cariprazine and centipene. She's on 4 mood stabilizers and 3 anticonvulsants, and occasionally a note saying that cariprazine is much more expensive than others, and shouldn't I try something else? This is the warning from Epic. I just pulled it right off, telling me that the maximum dose for protriptyline is 20 milligrams a day. Actually, the recommended dose for protriptyline is 15 to 40 in Goodman and Gilman, and in older editions of Goodman and Gilman, it's higher. Actually, you should go by level, but they're discouraging people. And then it says you should give this drug 3 times a day. Well, actually, the half-life of protriptyline is 74 hours. You give it once every other day and be just fine. So this is just nonsense. And you'd think that in something that costs $1 billion to put in, Epic costs $1 billion, in case you didn't know that. It's actually close to $2 billion now total. You'd think that they would look this up in Goodman and Gilman, put the right stuff in. So what is medical evidence? Well, there's data from carefully conducted experiments that most of you have heard about. There's clinical experience that some people have, and then there's clinical gossip that I get from Dr. Lipsy that helps me figure out what to do. The most compelling evidence is a clinical trial of an N of 1 in your patient. Been through is multiple clinical trials to find out what's going to work for him. And what works for him. It may not work for anybody else. So the risk-benefit analysis for using a drug is complicated. There's potential acute risks of the drug and potential long-term toxicity of the drug, but there's also potential acute risks of the disease and potential long-term problems related to the disease. And we try to balance those when we think about treating a patient. All the information you get from Epic and all these other sources is about the drug, but never about what would happen if you didn't use the drug. And that's something that you have to put into the equation because the computer isn't helping you much with that. And then there's efficacy versus safety versus cost versus length of stay versus insurance issues, prior authorization. I spend 10 hours a week on prior authorizations, I'd say, and patient acceptability. So there's opposing agendas in the provision of this information. For instance, you have an agenda of getting the guy better, and the patient has an agenda of getting better, but they also have an agenda of not spending their entire income on their medicines. The hospital has an agenda of shortening the length of stay and also decreasing the cost of the pharmacology that I use. So I get notes from the hospital. The insurance company has an agenda of, if you just get this patient to get off of our insurance, then we'd save a lot of money. But we're not going to pay for this, we're not going to pay for that. So generic drugs that cost the difference of a half a penny per pill for the insurance company, it's plenty for them to say, you should give this guy Zoloft instead of Prozac. The government's agenda about things, the legal office's agenda, and the culture's agenda about saying sometimes mental illness is a myth and other times mental illness is undertreated, depending on what's going on. So my first myth I want to talk about is polypharmacy is bad. I've been hearing polypharmacy is bad. Before I was a doctor, when I was in graduate school, the drum was beaten that you should use one drug, go up until it's toxic, and then switch drugs if it doesn't work. And that was based on zero data. Because I was in pharmacology graduate school, and they taught us that, and I went to look at the papers that show that polypharmacy is bad, and there aren't any. One of the residents said to me, I'm uncomfortable with the use of polypharmacy, and I said, me too. I didn't know being comfortable was the agenda. Prevalence and correlates of antipsychotic polypharmacy. This is between 1970s and 2009. This is a paper that a lot of people cited, and it showed that antipsychotic polypharmacy is associated with, it says, they say causes, but is associated with increased hospitalization rates and length of stay, increased adverse effects, increased treatment cost, and increased mortality. I'm just going to show you two of the papers. This is a paper from Ross Baldessarini's group at Harvard that I remember when it came out, it was a big deal. Retrospective case control, multiple versus single antipsychotics. The doses were similar in both treatment groups at the beginning, but toward the end, people on the polypharmacy had 78% higher chlorpromazine equivalents. The median length of stay in the hospital was 8.5 days longer. The risk of adverse effect was 56% higher, and the clinical improvement scores were similar for both treatments, whether you use monotherapy or polypharmacy. However, one of the letters, I didn't send this letter, the authors failed to consider the subpopulation that receives antipsychotic combinations. It's because they don't respond to monotherapy that they're getting the polypharmacy. That was kind of brushed off. And this is the paper that provoked, this is 2004, that provoked in 2007 and 2008, JCAHO to decide to target polypharmacy with, probably some of the older members of the audience remember this. JCAHO targeted multiple neuroleptics as one of their big issues. And they said, see, there's a paper. And then this is the other paper. This paper is widely cited, 88 long-term inpatients followed prospective over a 10-year period. It doesn't mention in most of the citations that it's an Irish rural long-term state hospital. And of the patients who died, an N of 39, 44%, the relative risk of death was 2.46 for the neuroleptic polypharmacy group. However, the relative risk for not getting an anticholinergic was 3.33, and that's because when you give people anticholinergics, if they're frail, they get delirious. And that's why they weren't getting anticholinergics, and they weren't getting anticholinergics because they were frail, and that increases your risk of death. And then having no teeth was just as bad a risk as polypharmacy. So this paper is widely cited, but not those other two things. The Joint Commission, and this is from 2008, said, I'm sure it's critically important, the Joint Commission said multiple standing antipsychotics is a potential quality of care problem. There's no support for the use of antipsychotic pharmacy, so they came after everybody about using polypharmacy for antipsychotics. This is a study, however, from JAMA from 2019 that looked at 62,000 patients, and it turns out that polypharmacy from the top down always correlates with better outcome in this study. Even the worst, which is, this is compared with Seroquel monotherapy down at the bottom, but even with some of the monotherapies toward the bottom, polypharmacy is clearly the better approach. And then this is another study of 61,000 patients showing that patients with schizophrenia following 14.8 years, polypharmacy was no more dangerous than monotherapy. And these are real studies. Why didn't we do those studies in the first place? Because the answer depends on how you design the study. If you're trying to show that polypharmacy is bad, you probably can come up with a way to do that. If you're trying to show what really is going on, then you take large populations with big N's and look critically at the data, and you find it's not. Well, what would be the agenda for decreasing polypharmacy? Well, it turns out that atypical neuroleptics were very expensive in 2008. They were costing a fortune. And you wouldn't want to use polypharmacy. Myth number 2 that I'm going to talk about is algorithms provide superior therapeutics. Standardized decisions better than your judgment. There are first-line agents. There's no first-line agent. When I was junior faculty here, the drug reps would come in and they would say, well, is sertraline the first-line agent for depression? Is fluoxetine the first-line agent for depression? Maybe they're both first-line agents for depression. There's no such thing as there's a first-line agent for your patient that is so multifactorial that you can't reduce it to an algorithm. In the HIV clinic, is clear that NNRTIs, non-nucleoside reverse transcriptase inhibitors, are more potent than protease inhibitors. So everybody in the country was using NNRTIs. Number 1, they have an increased risk of causing depression. Number 2, they're totally unforgiving. So if you're a clinical trials patient, which to get into the clinical trial, you have to show up for everything, then NNRTIs are good. If you're one of my patients, protease inhibitors are good because they're incredibly forgiving. You almost can't get resistance to a protease inhibitor. So everybody else in the country is using NNRTIs. I'm using protease inhibitors. And gradually, the HIV clinic here began to use way more protease inhibitors because it was clear that NNRTIs weren't good for my kind of patients who take their medicine on Tuesday, but on Wednesday they have to go out and do something, and 3 weeks later when they come back in, they've been off their medicine for 3 weeks. You want a protease inhibitor for that kind of patient. Warnings about drug interactions to improve treatment resistance are useful and improve safety. Never any data to suggest that, by the way. And suggestions for altering therapy from pharmacies, insurance companies, administrators are harmless and improve patient safety. So these are myths. It's not true they're harmless. They cause all kinds of problems. So how can a drug safety flag be detrimental? Well, the warnings may prevent clinicians from using the appropriate medications in the appropriate dose. Doses that are safe in everyone won't be adequate for some people. Safe in everyone, 0. That's the dose that's safe in everyone, because even a little bit of SSRI can cause SIADH. So lists of side effects don't describe the frequency, severity, and longevity of the side effect, and the placebo group toxicities are almost never presented. So when EPIC warns you, they don't say, these people had this side effect, but in the placebo group, they actually had more of this side effect. They just mention the side effect. And not wanting anything to go wrong means nothing can go right. This is something I learned as a resident at Johns Hopkins. You don't give anybody any medicine, they're not going to get better. So ketorolac is a non-steroidal anti-inflammatory given by injection, is clearly more efficacious for pain than oral NSAIDs. Ketorolac causes more renal failure. It is true. Ketorolac causes more GI bleeds. It is true. Because the dose of ketorolac that you give standardly is the equivalent of 800 of Motrin. And the dose of Motrin that you give is 200. But if you adjust the dose, it's no more dangerous than any other non-steroidal anti-inflammatory, and it's more effective. And on the pain service, where I'm dealing with patients who are withdrawing from 200 milligrams of oxycodone, I like something that has some efficacy for their pain, because I'm going to send them to PT. I mentioned it's expensive. I don't think that's the reason I get 50 warnings a week about it, but it could be. This is a study that looked at Veterans Affairs in Puget Sound, and they were very upset because they're finding that doctors are ignoring the flags. The critical warning override rate was 87% in 2006 and 88% in 2001, and the drug allergy override was 81% and was 69 in 2001. Override rates of critical drug interactions, drug allergy orders, are high at the VA Puget Sound VA. This is very distressing because they're ignoring, Dr. Lipsey, you are ignoring the warnings. So this is a cool study. This is in drug safety, and what they did is this is 2 health systems that recognized that their doctors were getting something called alert fatigue. Why were they getting alert fatigue? Because 58% of all orders generated an alert. More than half of the orders that people were writing generated an alert. And that's at one of these 2 places. So they said, look, we're going to convene a group and we're going to cut these alerts down. And they convened a group of people from the pharmacy and doctors and administrators, and each place had a panel, and they went after 2 different strategies at each institution to cut the number of alerts. And here's the results. In 55,000 orders at one place, and at 22,000 orders at the other place, there were alerts, and when you boil it down, by using the elimination process, you can get it down from 58% to 51% of all orders. And in the other study, they were able to get it down from 39% to 38%. And when they present how they did this, it's like a recommendation. This is no progress. This is not progress. Nobody's going to pay attention to these alerts if you get one half the time. So can we decrease alert fatigue? Now, I want to warn you something. This is Signal, something you can hook onto Epic that tries to decrease alerts and is carefully cultivated to do that. However, this study was paid for by Signal. I mentioned that up front because it's a little too good to be true. But Epic gave 27,000 alerts and Signal gave 1,600 alerts. And true positives, that is, the alert was correct, 979 for Epic, meaning 26,561 when Epic alerts were false positives. By the way, that's about my experience. I've gotten 26,000. They've mostly been wrong. Signal only gave 275 false positives. It gave 26,000 true negatives and 0 false negatives, whereas Epic missed 440 important drug interactions. And the result of their study is, the sensitivity for Epic is 68%, and the specificity is 0.3%. Now, I don't care about what Signal says, that they can get 100% sensitivity and 99% specificity, because I think that they paid for this study. I don't know how good their program really is. But I do think their data about sensitivity and specificity are probably right, that Epic is only giving you 0.3% specificity, which is not good enough to be worth getting all those warnings. So there's alert exhaustion. Most alerts are over drug-drug interactions. They don't cite their origin. They don't cite the paper. The alerts aren't reviewed by the pharmacy before we get them. And how do we really know about these drug-drug interactions anyway? What studies have actually been done? So there's thousands of known drug interactions, and they can be observed and clinically relevant, idiosyncratic, and potentially relevant. They can be idiosyncratic and potentially detrimental. They can be predicted in a variety of ways. But for every drug-drug interaction, where is the data actually coming from? And it turns out it's coming from all kinds of places, and it's been compiled into 6 internet sites that are the major source of drug warnings for all electronic medical records, and they're the place you guys look up drug interactions. And so somebody looked at the 6 big drug interaction databases that are out there, and they don't agree with each other, hardly at all. So they took 100 drug interaction pairs, and the agreement was 66%. And the kappa for severe drugs was 0.69, which is pretty good. But overall, it's 0.25. That's not very good. And there are drugs where one thing says this is a severe, totally contraindicated drug, and in another one it says there's no drug interaction at all. How could that be? Well, because this isn't carefully curated. These are theoretical from P450 numbers, or they're actual from clinical experience. So what do you need to consider? Well, you have to think about the pharmacodynamics and kinetics of your drug, absorption, distribution, metabolism, excretion. I've got some examples of ways that but the most important thing is the margin of safety or therapeutic index for your drug. That is, if the blood level were double, would that be dangerous? If it were quadruple, would that be dangerous? If it were tenfold increase, that'd be dangerous. So OCD, standing dose of fluoxetine is 20 milligrams. I've often given 200 milligrams of fluoxetine to people with OCD to get them better, and doesn't seem to cause trouble. How do you know? Didn't get any side effects. They didn't get serotonin syndrome. They didn't get trouble. They didn't have problems. So the SSRIs have a remarkably large margin of safety. Tricyclics have a narrow margin of safety. Lithium has a narrow margin of safety. So you have to know something about that. Why do you care? Well, fluoxetine has a half-life of 1 to 3 days, but one of its metabolites has a half-life of 7 to 15 days. And one of the cool things about fluoxetine is it inhibits its own metabolism as the level goes up. So the half-life changes on the higher doses of Prozac. The half-life gets longer as you go up, which means that people are reaching steady state in 2 to 3 months. And Cuprozine, kind of the same thing. It has a metabolite that has a 1 to 3 week half-life. And so if you take someone off Cuprozine, they may not be out of their system for 3 months. So you have to be thinking about those kinds of issues. But you can look the half-lives up, and you can think about it. These are the P450 enzymes. I just put them on this slide to show you all of them. I'm going to mention this one, CYP1A2, an important drug metabolizing enzyme, is induced by all the things in the top half of the slide and inhibited by all the things in the bottom half of the slide. You don't have a chance of figuring out what this enzyme is going to do to this drug's metabolism because it's too complicated. But for drugs that have a narrow margin of safety, you can get drug levels. For drugs that have a wide margin of safety, you can get drug levels too. They don't tell you much about therapeutics, but they do tell you when you're getting into the potentially toxic range pretty well. And you can always check them. This is the metabolism genetics chart with good. These are the drugs that have good data for genetics for the metabolism of drugs, and you'll see that they're rated A, B, or C. Nearly all the A's and B's are drugs where we use blood levels. Those are the ones that are dangerous, and those are the ones we use levels for. There's only a few that don't have blood levels, and most of the ones that don't, where you don't use blood levels, it's because they have a huge margin of safety. So you don't care if it doubles in half-life. You don't care if you're giving twice as much drug, because it doesn't seem to matter. What matters is if you give twice as much drug, whether the side effects give the patient trouble. So my suggested guidelines are know the half-life of your drug, the margin of safety, and renal and liver issues if your patient is compromised. Function and monitor toxicities in patients with narrow margin of safety and patients with a broad margin of safety. Just look for side effects. Recheck levels if you change drugs, if you subtract a drug, if someone has a major change in diet, recurrence, change in symptoms, and once a year or twice a year, depending on the patient, and get nortriptyline levels. I'm going to whip through these really fast, but these are 3 important studies that every one of you should know about nortriptyline level. This is the studies with amitriptyline looking at non-delusional and moderately severely impressed patients and showing that the therapeutic window for nortriptyline is between 100 and 150 nanograms per deciliter and comes back down as you get above that. This is a study using rabbit hearts, looking at the adrenergic neurons, and the doses that give maximal efficacy are identical to the doses that give clinical efficacy. And then this is a 3rd study looking at responders, true responders versus true non-responders. And again, the number they come up with is 93 nanograms per deciliter. They all agree that the dose for nortriptyline is between 100 and 125, 150 nanograms per deciliter. I have not yet seen a consult in the last 5 years where someone was on therapeutic nortriptyline. None of them. Consults I see, they've always been on amitriptyline or nortriptyline at 10 or 25 milligrams. Nobody checks blood levels. These papers have been out there since the 80s. Most people are unfamiliar with them. Your patient was not in the trial. give you data about the average patient who made criteria to be in the trial, and your patient already had nothing before they saw you and it didn't help. Try something. We know a lot less than we don't know, and we don't know how much about what we know that we don't know. Everything should be as simple as possible, not simpler. That's a paraphrase of Einstein. But things can't be as simple as the algorithms and the warnings make them. You have to be a critical thinker. If you don't get your patient well, that has just as many consequences as if you give them too much medicine. This is a 67-year-old woman referred for bipolar 1. She failed 8 years of medication trials with Dr. Lipsey. She was manic and depressed. She saw Dr. Lipsey. I think when I was a resident, he was the person I wanted to be because he knew what he was doing with drugs, and I learned a huge amount from him. And then she went to somebody else who's a graduate of our program for 9 years, and then she came to me, sent by somebody, and I said, gee, I don't think I can do as well as the people we've already had. And she said, well, I'm going to kill myself anyway. You don't have to do anything. As soon as my mother dies, I'm going to kill myself. And I saw her for many years, and after 8 years of treating her with everything I could think of, and that's a lot of things, this is her regimen. 50 milligrams of seroquel, 450 milligrams of bupropion, 200 milligrams of sertraline, and 2.5 milligrams of oxycodone at night and the morning. She's been stable on that and totally well for about 15 years now, with no variation. Now, if she got manic and killed somebody, you guys would put me in jail, because that's the craziest bipolar regimen I have ever seen. And I didn't get to that easily. But if you keep going, you get people well. Final caution. Administrators and politicians don't use evidence-based medicine. There's no evidence that EPIC has improved medical care or safety. The Joint Commission does not use evidence for its agenda. There's no evidence that HIPAA has protected anyone's privacy in the history of HIPAA. There's no evidence that the endless prior authorizations, length of stay campaigns, utilization reviews, or restricted formulas have saved any money in medicine. They have just increased the costs. And medicine is a service, not a business. Businesses don't receive philanthropy, and nonprofits should talk less about profit. This is my final slide. This is a patient satisfaction study done in 2012 that showed that people with increased patient satisfaction have increased mortality. If you think about what was going on in 2012, patients were more satisfied because they had more narcotics and benzos, and they died more. And what were we doing in 2012? We were paying places better based on their patient satisfaction scores. That became a target for reimbursement. At the same time, this study came out showing it killed people. Ask your doctor if taking a pill to solve all your problems is right for you. Why should I settle for good self-esteem when with medicine I could have great self-esteem? And finally, your insurance company authorized me to take out one. You pick. Take-home message. What we do is really complicated. It requires critical thinking. It requires reading the studies. It requires wondering once in a while, who did this study and what were they trying to show and why were they trying to show it and how is it useful to my patient versus being useful to somebody else. I'll stop. Thank you guys very much for inviting me back to Grand Island.
Thank you, Glenn. Fascinating talk. Lots of really, really interesting points. I'm tempted to ask you about the use of AI, but I have a feeling I know what kind of answer. So let me go in a different direction.
Okay, good. Can I just say one thing?
Yeah, sure.
I went to an AI talk at a big conference from a very famous computer guy, and he said, AI is a stochastic parrot. And he showed data to suggest that that's true.
Yes. Well, so let me ask you about the two antipsychotic issue. That was those recent papers you showed were fascinating, and I was not aware of them.
Well, they're not being promoted like the old ones.
Right. Well, that's
they don't save any money.
It's very compelling to see that data that says that two antipsychotics is not a bad thing. But tell us a little bit about your thinking when you decide to go to a two antipsychotic regimen.
Or five.
Yeah, no, I mean, how do you think about moving to...
So one of the things about antipsychotics is half-life. Your patient has to get up the next day, so you have to think about how sedated they're going to be on their drug the next day. But patients are very concerned about sleep, and you have to know which drugs are going to help them sleep better than other drugs. And these drugs cause various amount of weight gain. You have to know about that. One of the things worth knowing about is that olanzapine probably has an action at the alpranolone receptor that probably other antipsychotics don't have. That may be why it causes weight gain, but it certainly makes it more efficacious for me in patients with these complex comorbidity dysautonomia syndromes. So what I think about is, can I go up on this antipsychotic, or would I be better off adding a different antipsychotic that has a different spectrum of side effects? So for instance, Cenapine, Safras, most of you probably have not used Safras. It's a sublingual antipsychotic that was on the shelf when I was doing graduate work in the 70s, and nobody ever marketed it because it can only be given parenterally. However, somebody figured out you could put it under someone's tongue and it does great, but 2/3 bioavailable that way. So it came on the market. It's great for knocking people out. It knocks them out. If it works, it knocks people out. If it works, patient loves it. If it doesn't work, the patient hates it. A lot of people hate Acenapine. A lot of people love, one of my patients said, nectar of the gods. He was asleep, so I added Acenapine to his Seroquel, and that got him sleeping. But he was still agitated during the day. And he was really agitated during the day. And he was on lurasidone because it doesn't cause much weight gain. So what are we going to do during the day? Well, I gave him PRNs of Haldol. And he tolerated them remarkably well, and we went up and up. And he was on 15 milligrams of Haldol pretty much every day while he was in the hospital as he started to get better. And we cut him down before we discharged him. But he was discharged on all these different neuroleptics. We stopped his Seroquel because I didn't think it was doing anything for his sleep. But I think about half-life, weight gain, efficacy for psychosis, efficacy for depression as an augmentation, efficacy for other things like pain amplification, and kind of come up with a synthesis of what's going to be best for this patient's symptoms. And it is an issue of thinking broadly and also knowing the side effects of the drugs. And if you only use let's say, ziprasidone, you don't know the side effects of the other drugs. So you have to get good at them and know the different side effects.
Okay, thanks. Let's see, Dr. Tobolowsky.
Yeah, I'm curious what your opinion is about antipsychotic drug levels in their clinical use, and just if you have anything to talk about.
Yeah, so occasionally you'll get an antipsychotic blood level and you go, whoa! Maybe we need to back that down. But Dr. Toon, who was here before any of you were born, but some of us know him well, spent his whole career trying to figure out how to make Haldol, paliperidol equivalents or chlorpromazine equivalents, and how to balance that therapeutically. And it turned out he never could do it because we really don't know what the right blood level is of antipsychotics. What we do know is that in a huge study that was done, taking people down on their antipsychotics helped them just as much as taking them up on their antipsychotics. Now, again, that's a natural history study, so people were doing the right things. But it's always going to be, clinically, what can you see in your patient that would make you change, much more than it is some test that we could do. Eventually, by the way, we will have targets for all these things, and getting a pharmacogenetic analysis will tell you if the patient has the target that we're looking for. We're just not there yet. But I don't think the antipsychotic levels or chlorpromazine equivalents are very useful yet. I'd like them to be.
Thank you. Other folks? Yeah, Dr. Sharp.
Thank you for this talk. I was really intrigued by one of the points that you made, that like the trial and error people can identify regimens that are pretty specific to them and don't necessarily generalize how we generally approach people with their illness category. And then at the same time, there's all these different forms of standardization that are being applied from a lot of different angles that don't necessarily add up. And I guess I was wondering if you could offer guidance to individual providers on that problem. Want to develop your intuition for what's going to help a specific patient, but you're also having to find out.
Yeah, I think that it's a very good question. The guidance I have is ask senior clinicians why they do the stuff they do. So I used to ask John Lipsey, why he did the things he did, and I used to ask Peter Rabins why he did the things he did, and various other older clinicians. And Dr. Swartz and I, when we were starting out, were fascinated by the multiple things, but we also read the papers. And so if you read that paper, the schizophrenia bad outcome paper for increased mortality, as soon as you read that paper, you say, oh, this is crap. This isn't applicable to any of my patients. As soon as you read the increased cost paper, you say, gee, they're looking at a population of people with resistant disease. And so you have to read the papers and be critical about them beyond just looking them up in a book. If you're taking care of complicated patients, if you're taking care of easy patients who are straightforward major depression patients, you can use an algorithm. They work great. If the patient seems like they could be in a clinical trial, pretty good shot at just taking whatever the algorithm tells you. But when you have a patient that's complicated or who isn't getting well, then you have to start thinking critically about why people say you shouldn't use 2 neuroleptics, which I think is nonsense, or why you shouldn't use 2 antidepressants. Originally, when I wrote this talk, it had 140 slides, and I beat up STAR-D, and I beat up KD, and I beat up all these other big studies that create algorithms for what to treat, because they distort the data a lot that we actually know. And what we know is certain things are more likely to get your patient better than others, but often have more risk than others and more side effects than others. So you're trying to look at your patient and say, what should I do? Lithium augmentation versus neuroleptic augmentation in my antidepressant. And it just depends on the patient.
Dr. Redgrave.
Thanks, Chris. That was great. Can you comment on sort of on GeneSight and those companies, because it seems like there's a lot of pharmacology there, and I tend to try to treat the patient rather than some report that says I should be using XYZ drug, but it's something that patients bring not uncommonly.
Well, so those tests right now are very expensive. And the patient pays for them, and so they're very invested in using them because they paid for them. There was a recent paper reviewing them carefully. Basically, the conclusion is not ready for prime time. What those papers look at is all metabolism stuff. They aren't looking at targets for efficacy. Now, Dr. Potash will tell you that certain people with genetics have a short promoter for catechol-methyltransferase, let's say. But that only accounts for a small percentage of the variance in depression. But 5%, 3%, what is it?
Exceedingly small.
Very small. So those things don't target those things yet because we don't have enough targets genetically to say, okay, if this person has these 3 genes, they're going to respond to this drug. All it tells you is there's this increased risk of slow metabolism for sertraline. Well, I don't care if people have slow metabolism for sertraline. I go by response, and I push it up. 200 of sertraline doesn't do it. I go to 250. 250 of sertraline doesn't do it. I go to 300. It's pretty safe. If they get toxic at 300, I do something else. So I haven't found them useful yet. I've looked at them as they've come out, and I think that they generate a lot of revenue. But I don't think they're ready for as a tool for us to make a difference.
Thanks, Glenn. One more question, Dr. Sedlak.
It says call the pharmacy right now because you gave someone Toradol. We're going to hang you.
Corollary of one of your studies presented, others have found that patients with schizophrenia diagnosis have better outcomes when also taking the antidepressant. But broadly speaking, do you have any suggestions for how discipline or the AMA can educate insurers that not every patient is represented by guidelines?
The advocacy for us to be professional experts and clinicians rather than interchangeable providers is small. The advocacy for us to use algorithms and therefore not be experts and therefore anybody can do it, including a PA with 45 minutes of training, can do what we do because they can look at the algorithm as well as you can. That is hugely popular right now and hugely promoted. And so promoting ourselves as real experts, as knowing something that you can't look up on the internet, is extremely difficult. It needs to be promoted. I try to promote it. Other people try to promote it. Judgment, careful evaluation of patients. You can't do it in 45 minutes. You need 2 hours. Dr. Schwartz needs 2 hours. I need 2 hours. Other people need 2 hours. They're all obviously wasting everybody's money. But the idea that you learn something and become an expert at it by practicing it, because it's called practicing, over a lifetime, is unpopular right now. Because if they change the panel, now you're changing doctors. Well, it doesn't matter because they're all using the same algorithm. And we have to push back against that. And it's something that we all should be pushing back against all the time. And it's exhausting. But I yell at the pharmacy all the time. And on the P&T committee, they would rather I didn't show up. But somebody has to go and say, no, this is how doctors do what they do, and explain it. And it's not simple. Toxicity, severity of the illness, half-life of the drug, previous treatment experience, how certain are we of the diagnosis, what are the other diagnostic possibilities. It's just really complicated and requires this complex multifactorial assessment that isn't done on a one-dimensional algorithm. And the AMA has to recognize that and advocate for doctors as professionals and not as employees. One of the things I'm worried about is that we're going to unionize as physicians. I'm worried about that because right now there's tags that say management and physician. And if they're management, what are you? Labor. And if you're labor, they tell you what to do. If we're professionals, they don't tell us what to do. You have to really fight back. It's insidious.
Thank you, Glenn. Yeah, no, the thing I was getting at with AI is that it's really just to amplify the things you've said. There's so much talk about AI now. And like you, I think the idea that AI is going to be able to provide us with definitive guidance in any given situation in the near or foreseeable future is very, very low. I don't think it's going to replace us. I think probably what it could do usefully is provide a menu. In this kind of situation, this, and this are things to consider. You know, that probably would be helpful. But I'm
I don't know if it's going to be helpful. I think you're more likely to learn that from Dr. Lipsy or Dr. Rabins or you.
Yeah, no, I know. I'm just going to wrap up since we're out of time. But, you know, I think your rounds is really valuable. A lot of very useful lessons for all of us. Thanks so much. Appreciate it.
Thank you. Thanks a lot. Thanks, everybody.